So good afternoon, everyone. We have the last multi-head session here before the holiday, and I have a bunch of mesenchymal tumors here. The first case is from a 70-year-old male who had a tumor in the wall of his stomach. And this is the scanning magnification. It's a well-circumscribed tumor. Which, on higher power, consisted of these atypical epithelioid cells with abundant cytoplasm. And you can see the quite prominent pleomorphism. In contrast to that, the mitotic activity was relatively low. I don't recall the exact number, but there wasn't any significant mitotic activity there. So here is quite a broad differential diagnosis, of course. You can even think of some carcinomas given the epithelioid morphology, but that's unlikely because if you had a carcinoma like this, it would be in the wall of the intestine. There would be some mucosal involvement as well, which wasn't the case here, and carcinomas with this kind of pleomorphism would have very high mitotic activity, which was not the case here. I could think then of melanoma, which is similar story. Again, you would see multiple mitoses, necrosis, and so on. Then for mesenchymal tumors, you could think of some leiomyosarcomas, but again, with this kind of pleomorphism, you would have very high mitotic activity. Then you could think of glomus tumor, which definitely is, for me, would be the number 2 differential diagnosis in this case. And then very important and relatively common tumor in the stomach, which is GIST, of course, gastrointestinal stromal tumor, which typically presents with spindle cell morphology, but about 10% or 15% of cases are caused by, not by KIT mutation, but instead by PDGFRA mutation, which is a similar kinase gene. And tumors with PDGFRA mutation, again, they compose 10 to 15% of GISTs. They present exactly with this kind of epithelioid morphology, and are typically found in the stomach as well. So for me, that was the number 1 differential. So you do CD117 or c-KIT immunohistochemistry. You could see some expression here at the periphery and some very weak expression in some of the epithelioid cells. So this is hard to say whether this is enough or not for GIST, but there is some expression. And then you can do DOG1, which is a somewhat better marker than c-KIT, and it shows similar expression, focal and weak, but there is some expression. With PDGFRA mutated GIST, it's important to remember that the c-KIT or the CD117 immunohistochemistry is often completely negative or only focally positive. So the expression we saw on the immuno is not actually too bad for it. I'll show it again. Focal, weak, but definitely some expression. So this is pretty good for PDGFRA mutated GIST. So better marker for these tumors is DOG1. In this case, it wasn't perfect either, but together we have 2 markers for GIST which are focally at least weakly positive, so that would be enough. And we also did mutation profiling, which confirmed PDGFRA mutation. So this is a PDGFRA GIST. Again, 10 to 15% of GISTs, typically found in the stomach. Some cases, a fraction of them can be familial. So when you have, germline PDGFRA mutation. So next case was a 39-year-old female with a tumor on her lower leg. It's a skin excision, epidermis with this mild hyperplasia, and notice this hyperpigmentation of the rete ridges, which is kind of useful feature. And then in the dermis you have this varicellular proliferation. The proliferation consists of, again, kind of like epithelioid cells with very prominent clear cytoplasm. If we go on higher power, you can see it's slightly granulated. Looks like foamy cytoplasm, foam cells. And indeed, these are, if you do CD163 or some other histiocytic marker, these are histiocytes, and the foamy stuff are lipids. At the periphery, you can see entrapment of collagen fibers. In this area, for example, by cells which don't have this foamy cytoplasm. And this is actually just a special variant of fibrous histiocytoma. It's a so-called lipidized variant of fibrous histiocytoma, which differs only in the presence of very abundant lipid deposits in the cytoplasm, giving it this clear cell appearance. Often also the stroma is prominently hyalinized. You can see a hint of it in this area, this pink hyalinization. Sometimes it's very prominent. And another special feature of this variant is that it typically is found on the lower extremities, lower legs, especially around the ankle. It used to be called, or sometimes still is called, ankle-type fibrous histiocytoma. So just a special variant, again, this hyalinization of the stroma. Important features to recognize this as fibrous histiocytoma is the collagen entrapment at the periphery and the epidermal changes above. Okay, this is a nice case. I don't know the exact location, but most cases of this tumor occur on the extremities. This was a case we received for a project we are contributing to. So at some areas you see mature adipose tissue. You can see we are deep in the muscle, so deeply located tumor. This is a skeletal muscle. And while in these areas you see mature adipose tissue, when you go in other areas, such as here, the picture changes a little bit. And you see this mixo hyaline to mixochondroid stroma, and you'll see also many lipoblastic cells here. So these are lipoblasts, immature fat cells. There's a very large quantity of them, and together with the background of mixochondroid stroma, it's this bluish, grayish color right here. This is called mixochondroid stroma in the center, for example here. It's not very prominent here, but at least something. And together with the mature adipose tissue at the periphery, this gives you the diagnosis of chondroid lipoma. It's a special variant of lipoma with completely different genetics. There is typically MKL2 fusion, which was confirmed in this case. So you have here the immature lipoblastic appearance of the adipose tissue combined with the mature adipose tissue. Typical location again, extremities deeply located inside of the skeletal muscles. Yeah, and here,
it's very rare.
Yeah, it's super rare. I've never seen one in real setting. Neither consultation, neither routine. This is just.
We have some, but I didn't see it for years now.
Yeah. Actually, this is a different case with the same diagnosis. Again, you see mature adipose tissue with some secondary changes, and then again this mixochondroid stroma and very prominent lipoblasts, especially here, for example. So it will take a long time until we see another case like this. Again, I don't know the location or age here, but most likely extremity. Actually, at about the same time I received this case as a consultation, another lipomatous tumor, and kind of this bluish grayish background, mixochondroid a little bit, mature adipose tissue, and a lot of lipoblasts. The only thing that was different here was the vasculature, this prominent arborizing vascular channels, long slit-like vessels, which are typical for myxoid liposarcoma. But otherwise, the overall appearance is somewhat reminiscent of chondroid lipoma. But in this case, there was DDIT3 expression by immunohistochemistry, which is a surrogate marker for FUS DDIT3 gene fusions, which are seen in myxoid liposarcomas. So this is a myxoid liposarcoma, low grade. I don't recall the location here. But again, typically young adults, tumors on the thigh. Again, here, beautiful example of the vasculature, typical vasculature for myxoid liposarcoma. And at about in the same week, another case, which is somewhat in the differential of these tumors, it was a knee area of a 75-year-old lady. So this is a superficially located tumor somewhere in the subcutis, which is important in lipomatous tumors. Whenever tumors are superficial, they are very likely benign. Even without looking at the histology, there is a high chance that the tumor will be benign. So this is superficial tumor. You see mature adipose tissue with minimal variation in the adipocyte size. Some myxoid areas, again, this bluish color. Right here, you may see few lipoblasts. Small number of lipoblasts isn't important, isn't useful for anything. And so here you could think of either myxoid lipoma, ordinary lipoma, a myxoid variant, or myxoid spindle cell lipoma. I think we have still areas with this quite prominent spindle cell stroma, with these spindle cells here. So for me, I favored spindle cell lipoma, which is typically, of course, strongly diffusely CD34 positive, which is the case here. This is CD34. The stroma areas are diffusely positive, and there is RB1 loss in the fat cells and in the spindle cells. It's kind of hard to evaluate it in the fat cells, so I recommend looking in the spindle cell areas where you see expression in the vessels, but loss of expression in the spindle cells. I also did MDM2 immunohistochemistry, which was negative, just to make sure this is a benign myxoid spindle cell lipoma. Okay, this is a beautiful case. Just a routine biopsy here from Vyoptická. The patient was a 67-year-old male with a tumor on his, I think it was lower leg. And we have these fragments of fibroadipose tissue with pieces of this tumor, which consists basically of spindle cells, and then this very prominent vasculature, which is a little bit similar to the vasculature we saw in the myxoid liposarcoma. example, these arborizing thin-walled vascular channels. But of course, everything in between is different from from myxoid liposarcomas. So you see just very bland spindle cells without mitotic activity. If you do immunohistochemistry, there might be some focal expression of CD34 or desmin or EMA, but it's not diagnostically useful. This case was negative for everything, but this morphology is very suggestive of a diagnosis of one very rare soft tissue tumor, which is called soft tissue angiofibroma. And the only way to confirm this diagnosis, if you are not, if you think the morphology is not sufficient, is either one new antibody, which we don't have, I don't even remember how it's called, CYP something, or you can do molecular genetics, because these tumors typically have either NCOA2 or NCOA3 gene fusions with AHRR gene as fusion partner. We did molecular, and there was indeed a fusion of AHRR and NCOA3 gene fusion, which is the rare fusion type. So this is soft tissue angiofibroma. This is one more example, older case from our archive, 52-year-old gentleman with a tumor on his finger. And again, pretty similar morphology, again, very prominent vasculature, small thin-walled vessels here with little hyalinization in the vessel walls. So soft tissue angiofibroma, the exact name is important because we have a bunch of other angiofibromas in pathology. So soft tissue angiofibroma or angiofibroma of soft tissues is the correct name for this completely benign tumor. Typical location is again extremities, lower more than upper extremities, but
it can be huge. Yeah.
Yeah, they can be large tumors. They were often misdiagnosed previously as perineuromas, and sometimes even as myxoid liposarcomas given the vasculature. And here, just to show you, this is a 61-year-old female tumor on her vulva, and this is case of another angiofibroma, but this is called cellular angiofibroma. Unfortunately, the names are very confusing. Both were proposed by Dr. Fletcher, who liked the word angiofibroma apparently. So this is cellular angiofibroma. That's a tumor of anogenital region, of especially females, but also in males. Again, completely benign tumor with prominent vessels, but in this case, the vessels are more, dilated, roundish, as you see here. And the stroma in between is more cellular. That's why it's called cellular angiofibroma. These tumors are usually CD34 positive, and they have RB1 loss and RB1 alterations by molecular. They actually belong to the spectrum of spindle cell lipomas, mammary type myofibroblastomas, and other RB1 altered soft tissue tumors. So cellular angiofibroma. The one before the case. Show again. So as first one, this one is called angiofibroma of soft tissues. Then there is one more angiofibroma in pathology, and it's usually called skin angiofibroma. It has alternative name as fibrous papule. Those are two small, tiny tumors typically on the nose or on the face. So these three angiofibromas can be found in pathology. Okay, this is a case I got from my father. It's a tumor from a sacral area. Even the clinician said this is a lesion in the area of a decubitus. It was a 57-year-old lady. And this is what we got. Some fat tissue with some secondary changes. Skeletal muscle with some vascular proliferation here. And importantly, diagnostically very, very important, you see this huge fibrinoid necrosis in the center. So this is a picture of so-called atypical decubital fibroplasia, which today is more often called ischemic fasciitis. This is a lesion occurring in areas which have been in the area of long-standing pressure-induced ischemia. So typically, patients which are immobile, which are lying in bed for many weeks, and so these lesions typically occur in the sacral area or in the area of the scapula, or some other areas which are in long-term contact with the bed. Sometimes you can see it also in patients with crutches around the elbows and areas like this. And the very diagnostically helpful feature are these prominent areas of fibrinoid necrosis, which in the center, which then continuously transform into areas like this, which are composed of these fibroblastic cells, which are often atypical. That's why it's called atypical decubital fibroplasia. So you see also prominent nucleoli sometimes, but importantly, there are usually not many mitoses, and there are no atypical mitoses. So this fibroblastic or myofibroblastic cells, which kind of are mixed together with reactive vasculature, as seen here. Also here, it's kind of chaotic small vessels which have been newly formed. Also, you can see the reactive vascular proliferation inside of the muscle. So atypical decubital fibroplasia, a completely benign lesion. It's non-neoplastic. And my last case here, which was an 83-year-old lady. It's a lesion around the elbow. And I think this is actually the same thing, just a small sample. I just didn't have the information about any decubital changes. So I just described it and asked for clinical correlation. You can see again some fibrinous areas, possibly fibrinous necrosis, and some fibroblasts, myofibroblasts, which with atypia but without mitotic activity. I did a lot of immunohistochemistry, everything was negative. There was some smooth muscle actin expression, which is normal. Here you can see reactive vascular proliferation. And so I think this is another case of small atypical decubital fibroplasia or small ischemic fasciitis. Just this small sample, I don't have anything else. Okay, that was my last case. I think my father has a few cases, but just left somewhere, so I'll go find him and bring him back. Just wait a minute.
Goed, ja?
Ja.
Oké, sorry. Telefoon schijnt niet meer te gaan. Oké. Dat is ook een beetje. Even een beetje in de hoofd. This is. I'm going to show the biopsy I got right now. my microscope today. It is a lesion from parietal region. You see, there is some hyperplastic epidermis, but what is most apparent are these vascular proliferation in superficial part of dermis. Yeah. The question was, is it sort of hemangioma, hemangiosarcoma, whatever, or Kaposi sarcoma? But there is one important thing you should take notice of. In hematoxinosis, it's seen only in small suggestion. Do you see in the HNE slide here elastosis of the dermis, deeper in the dermis? So I did elastica staining. And the elastica staining looks like that. You do see that band like hyperplasia all over the lesion, going deep to the dermis. So my diagnosis here would be elastolytic hemangioma, which is typical hemangioma that is arising inside or above elastosis of dermis. And according to me, the elastosis is the first thing, and the vascular proliferation is reactive over the elastosis, so that in these areas of dermis, the skin is very fragile and very easy to be injured. Yeah, so I think this vascular proliferation is reactive to elastosis in the dermis. Yeah, it's not that rare. We have maybe 10 cases, and we see it from now and then. Yeah. Here I have a newest case of pigmented lesion. We saw very similar very recently. And if you see the cytology of it, it is enzyme protein positive. I think without further examination, everybody would say that it's clear-cut melanoma. Then the stain is substain, which is typically positive. And the stain prame. Prame is positive in big part of a large percentage of the cells, only supporting the diagnosis of a malignant pigmented lesion. And the last thing, the staining for BAP1, and you see it's negative. The positive are hematologic cells, yeah? Or in the lower part, positive are the original. Okay, I should probably I should look. Here you can see it's BAP1 negative, so that it's BAPoma or BAP1 deficient nevus, but in this case I'm not sure that it's benign. I will be marked to the clinician that it must be one of extremely rare, probably melanoma arising or being BAP1 deficient. There are described very few cases, I think 3 or 4 cases. We published recently a huge series of 51 cases of BAPomas, and only one was malignant. Yeah, so it might be the second malignant case, but only history can tell us what's going to happen with this patient. Here I have nasal papillary lesion or nasal papilloma. But in one part, on jsem pustil, prosím tě, stop, tak si s tím hrál ten, sorry. We had a visitor here during the last week, and he was from United States, used not to use the holder for the slide, so that the holder is here very badly taken. Yeah. But the lesion was having, you can see here, the ceremonal hamartoma with atypical glandular structures. But in addition, there are these islands of cells which have such mucinous differentiation, so that it looks like even adenoma or something like that. The lesion was EGFR, EGFR mutated, so that it's mutation of typical inverted polyp, and I still think that it is inverted polyp, and these are just mucinous metaplasia in the solid areas of the polyp. It's unique, yeah? It's never published so far, and we are trying to get more cases. This is ceremonal hamartoma with atypical glandular structures here. It's funny that they are described only 3 types of papillomas, sometimes Schneiderian papillomas, called inverted, everted, and oxyphilic. But in our opinion, there may be maybe 10 types of these papillomas, and we are now mapping them, doing genetics, so that in the future we would like to bring new entities from this area. Yeah, here I have large excision of perianal lesion. I once showed you probatory excision of it. It's an excision from the male of perianal areas. And you see that somewhere there are foci that could be already classified superficial incipient squamous cell carcinomas. Yeah, we warned surgeon that he should take it at least 2 millimeters to the deep of dermis, so that it was done like so. And another interesting thing here is epidermis, which is having atypicality in basal areas. Yeah, you see the basal areas which are atypical, and these are P53 positive, and even you can see here you can see very nicely that atypicality of epidermis. There is some sclerosis in the upper part of dermis, so that I think the patient has lichen sclerosis in perianal region, which is quite rare in males. Yeah, this is a differentiated type of dysplasia, and I think that what is seen in the patient, typically prolonged rete ridges, and at the tips of the rete ridges there is absent basal membrane, and they invade in a thin-like staghorns into the dermis. Yeah, you can see it here. Yeah. We think that this is already microinvasive carcinoma. Here you can see when on the tips the basal membrane is missing, and when the epidermis becomes pink-like stained, it's the same pink-like change like in cervix, it's already microinvasive carcinoma. It is our experience that these very incipient squamous cell carcinomas do not reach lymphatics, and we never saw a case that would metastasize being developed as that. Just what is imperative is that the lichen sclerosis is very often multifocal lesion, and there may be another focus of lichen sclerosis with the same process being in here I have another block from the same patient. Yeah, you can again see here elongated rete ridges with eosinophilia and lack of basal membrane, so that again microinvasive. In cervix, the eosinophilia of the bulbs at the bottom is very important sign of microinvasion. Okay. I have another slide, and again eosinophilic change with prolongation of rete ridges with loss of basal membrane. Again, you should put into the finding to surgeon that the lesion is excised in toto, that the rete ridges do not touch the bottom of the excision, and that these very microinvasive cancers usually have good prognosis as to the metastatic behavior. Here I have nasal polyp. Nasal polyp, and one would say, is it already Schneiderian papilloma or not? I did the genetics just to know whether these lesions are already having the typical EGFR mutation. Yeah, and this case already has it, so that these lesions represent already fully formed inverted polyp. And we should repeat, the inverted polyp are much more great diagnosis when aberrated polyps. These inverted are having 5 to 10% possibility to metastasize. Usually the malignancy of squamous cell carcinoma is clear cut. It's quite, the dysplasia is quite easy diagnosis. Yeah. Averted papilloma is malignant very rarely. Here is a tumor of eyebrow, skin of the eyebrow. Typical of these tumors is some degree of atypicality, usually not a big one. You see, and snouts like proliferation into the lumen. I think I have one more focus there. Yeah. The diagnostic of this is this part, which you see. There is some hyperplasia, atypicality with the proliferation of microsnouts into the lumen. And when you stain these lesions by antibody to BRAF, you usually have positive result, because these lesions are usually BRAF mutated. And the diagnosis of that is tubular adenoma. And we published already many years ago, 15 years ago, this nice report, which is cited everywhere. And we found that we found that this tubular adenoma, sometimes in the past called apocrine adenoma, and syringocysternum papilliferum are one of the same lesions. Just syringocysternum papilliferum is open to surface of epidermis. Tubular adenoma does not have this opening. Yeah. Otherwise, they look the same, and we think that they represent the same entity. And both of these lesions are BRAF mutated. Yeah, and both of these lesions can have atypical atypicality in these ductal structures, so that it may be a pitfall. Yeah? When you stain it with Soxten or S-hydroprotein, you see intact peripheral layer, yeah? By which you see that it's not invasive lesions, but this intraductal growth is sometimes very prominent. You should not call this malignancy. Yeah? And these lesions are quite frequent. Yeah? You definitely every pathologist will ever find them. Yeah? Here I have cervical biopsy. And you see high-grade, deeply basophilic tumor. And morphology of this tumor is indistinguishable from endometrial serous carcinoma. But in the cervix, it's different etiology of the tumor. In the cervix, these serous-like carcinomas of cervix are HPV driven, so that this case was HPV 16 positive. And these lesions in the cervix have much better prognosis than endometrial serous carcinoma, which are HPV negative. So that it is imperative to make HPV testing and do not do P16. P16s are positive in both of these lesions. Only only P16 genetic testing distinguished these two lesions. Yes, here I have pigmented lesions of the skin, which is relatively well differentiated, but still I think no doubt that the lesion is malignant. And we have three lesions that are very similar to this. These lesions, when you stain this retinoblastoma protein, are RB deficient, and this deficiency can be seen on genetic examination as well. Yeah. RB1 deficient melanomas were never described in the literature, so that we are not very sure what is the malignancy, but still we have already in our files from recent cases 3 lesions of RB1 deficient malignant melanoma. It is another different case. Melanoma, which was RB deficient. Another case back to cervix is this lesion, cervical endocervix, yeah. And here is something this of notice. You see this cellular spindle cell proliferation just under the epithelium. It is our experience that this usually arises as reactive to injury of superficial epithelium, but it's called superficial cervical stromal endometriosis. I'm not sure whether it's the right name because I think it's reactive, but you never find glandular differentiation in these lesions, and especially they should be distinguished from spindle cell sarcoma, especially rhabdomyosarcoma, especially those arising in DICER1 syndrome, DICER1 mutation syndrome. Yeah. These are innocuous, they mean nothing, they do not do anything. One sign is that you can always find reactive lesions in the superficial epidermis of it. Yeah, it is tumor of the thyroid. It's quite rare type of tumor of thyroid. When you see cytologically the papillae that are confluent, these confluent papillae are very different from papillary carcinoma. And their cytology is something between papillary carcinoma and follicular lesion. You see, and this confluency is not seen in papillary carcinoma. Still, it's different from follicular lesion. It's always non-encapsulated. Among great help is when you stain these lesions with beta-catenin staining, which are always and must be beta-catenin positive. You see nuclear positivity. And its special type of carcinoma of thyroid is now the name morular cribriform carcinoma of the thyroid, which is a rare type of lesion described in the 90s. And sometimes it is associated with syndromes, especially Gardner syndrome or other syndromes. Yeah. This is the same malignant tumor as this papillary carcinoma of the thyroid. Yeah. It's quite rare tumor. Even if I say that I saw 5 or 6 cases in 2 years, but now it is the case I saw after many and many years. Yeah. This is tumor of heart pellet. It's case from Alena Skalova. Tumor of heart pellet. Which can be diagnosed from H&E slide. Yeah? It is having slightly clear cell morphology. It is composed of one cell type and very often produces these mucinous legs that can make people confuse it with secretory carcinoma. We did molecular genetics, and it was ETB6 pericardium 1 fused tumor, which is fusion that was never described in cerebral tumors, but pericardium 1 PRKD1 is typical mutation for so-called cribriform carcinomas of minor salivary glands, which we described as Alena in 1998. Yeah, so that it's new mutation, and we have more new mutations, and I'm sure that we describe many more mutations, but always the fusion partners pericardium 1, pericardium 2, or pericardium 3, of which pericardium 1 is the most frequent. We think that it is entity different from low-grade polymorphous or high-grade polymorphous carcinoma, even if in WHO classification they are considered 2 variants of the same thing, but these 2 tumors, polymorphous and carcinoma, behave entirely differently from this one. This one very often, very early metastasized. The metastatic foci are very radiosensitive, and usually the patient do not die of the lesions. Pericardium 1 is said to metastasize only in 5%. Polymorphous low-grade adenocarcinoma is said to metastasize only in 5% of the cases, and I think that this metastatic foci in polymorphous low-grade are caused by mixture of polymorphous low-grade with this tumor. If you would take these tumors away, you will find out that polymorphous low-grade never metastasize, according to me. I even did whole research everywhere, and we found that if some group published series of polymorphous low-grade adenocarcinoma with, let's say, 5% metastatic foci, they were usually on the tongue, and it is very well known that 70% of these tumors, cribriform carcinomas that you now view, are present of the tongue, so that we think that they merge together 2 different entities with this one, and this is the one that metastasizes. So main message is, when you see this tumor, look for the metastatic foci, usually in neck lymph nodes, and inform the clinician that they should be irradiated. They are very radiosensitive. So they have similar properties like papillary carcinoma of the thyroid, which is very often mistaken for it. When you have lymph node, take the metastatic first, you find this lesion. Usually everybody is thinking about metastatic papillary carcinoma of the thyroid. Yeah? When you make thyroid hormone, they are negative. So you always second diagnosis by exclusion is cribriform carcinoma, being in 70% in tonsil and 30% in middle salivary glands. Yeah, here I have very interesting and important diagnosis. It is diagnosis. It is lesion of the cervix. And you can find this process to be very often on cervix, vulva, vagina, and and conjunctiva of eyes. And you see deposit here, eosinophilic deposit of amyloid-like lesions under the epidermis. When you study this amyloid, they are perfectly negative. And the way to make diagnosis is to call gynecologist and tell him, look into the conjunctiva of eyes, and he will have white deposition in mucosa of eyes. And this is so-called ligneous cervicitis. And these patients are having genetic block on production of plasminogen, and they store plasminogen product in subepithelial structures, so that these deposits are very nicely seen in macroscopically. Here I have another patient of the same processes in vagina. It's different patient, but process in vagina. And look, he is very nicely seen how these eosinophilic deposits are seen just under a surface which is sometimes ulcerated. Yeah. And you see these eosinophilic deposits. Another place where you can find this eosinophilic deposit in these patients, beside conjunctiva, is external ear. You should look at the external ear of the patient as well. They amass these something plasminogen containing eosinophilic mass in these lesions as well, in these areas as well. Okay, it's everything from me today. It's nearly 4:30. We probably will now. Next week is already our holidays. We won't do seminars in holidays, so that we invite you again to our Tuesday seminar starting the beginning of September. Yeah. Thank you for attention, and have a nice day.